Best muscle graft for scalvis injury of carotid arteries, rectus abdominis, temporalis, quadriceps, and longus capitis muscle. And why crust muscle is used? Answer of this question is best muscle graft is the longus capitis muscle because its muscle is easily and quickly harvested during endoscopic sinus surgery and it is seam site accessible muscle. The advantage of harvesting a nasopharyngeal muscle graft during endoscopic sinus surgery that is this muscle is readily exposed after incision and reflection of nasopharyngeal mucosa overlying the clivus. Most importantly, in stressful event of IC injury, the surgeon can quickly harvest the graft immediately after obtaining the primary bleeding control without need to remove the endoscope, change instrument and expose an additional operative site. Thus, this method risk of losing visual control over the surgical field is minimized. So this site is better. Why crust muscle is used? Because crust muscle having coagulation factor 4 that is calcium. If you crushing the muscle, more calcium is releasing and more coagulation activity of the muscle which will be there. Second question. Best method to control scalvis injury of carotid arteries, bipolar cortical, aneurysm clip, hemostatic material, muscle patch packing. Answer of this question is muscle patch packing. The most effective method of primary hemostasis are the muscle patch and aneurysm clip. When considering the technical difficulty of applying a clip to a short segment of curving vessel, the muscle patch may be more suitable for a variety of situations and may be less likely to stenoze or occlude the ICA. So best method is the muscle patch packing. Carotid injury is a devastating complication with up to 30% of patients having neurological sequelae and approximately 20% mortality. Carotid injury is one of the most challenging endonasal situations requiring both calmness and skill from the surgeons. Best way to handle such complications. Recommend use of crushed muscle patch on the bleeding vessel. This is the quickest, safest and most effective way to handle such complications. Inadvertent injury to ICA is the most critical situation in the endoscopic sinus surgery or skull base surgery. In the setting of IC injury, maintaining the visualization and control over the surgical field is the first step of the management. The collaboration of two surgeon team provides a great advantage since dynamic endoscopy maintains visualization and allows localization of bleeding site, and the four hands technique allows for quicker alternation of instruments and to clear the field of vision. So four hand technique you can handle the bleeding as well as you can handle the suction port and you can put the muscle graft. Vessel preservation techniques are sealing the defect with bipolar cautery, applying the aneurysm clip, or packing with muscle patch or other hemostatic material. However, there is not a single technique suitable for all scenario of IC injury. The hemostatic technique should be tailored for mechanism of injury, location and size of the bleeding site, and extent of surrounding exposure and patient collateral circulation. All these are important point to consider the management of IC injury. The most effective methods of primary hemostasis are the muscle patch and aneurysm clip. When considering the technical difficulty of applying clip to a short segment of curving vessel, the muscle patch may be more suitable for a variety of situations and may be less likely to stenose or occlude the ICA. Before being applied to the bleeding site, the muscle paste should be crushed to release calcium, as calcium is known as factor 4 in the hemostatic cascade that promote the normal clotting process and enhance the clotting activity of the muscle. In order to be effective, the patch of crushed muscle must be held in contact with injured vessel wall for a few minutes. During this time, the amount of pressure exerted on vessel wall can be varied and carotid flow can be assessed by a Doppler probe to confirm patency of ICA during and after hemostasis and packing of the muscle patch. Suitable muscle graft from the longus capitis muscle could be easily and quickly harvested during endoscopic sinus surgery. Other common muscle donor sites are abdominis, rectus, sternocleidomastoid muscle, quadriceps, and temporalis muscle. The advantage of harvesting a nasopharyngeal muscle graft during endoscopic sinus surgery that it is easily readily exposed after incision and reflection of nasopharyngeal mucosa overlying the clivus is the most suitable and accessible site. Most importantly, in the stressful event of IC injury, the surgeon can quickly harvest the graft immediately after obtaining primary bleeding control without need to remove the endoscope, change instrument, and expose an additional operative site. Thus, with this instrument and with this method, risk of losing visual control over the surgical field is minimized. The high-risk cases for carotid injury are revision surgery cases, invasive tumors in the skull base, displaced IC cases, and prior irradiation cases. The longus capitis muscle graft can be harvested at the beginning of surgery with minimal additional morbidity for the patient. In these type of cases, that high-risk cases like revision surgery, invasive tumor, displaced ICA, and prior irradiation cases. In spite of convenience of nasopharyngeal muscle graft, it is difficult to perform the muscle graft or harvest the muscle graft at the same time as obtaining primary bleeding control. This may be a limitation of local harvest than the secondary site. Though the size of longus capitis muscle may be somewhat restricted compared to abdominis or rectus abdominis muscle or temporalis muscle, but it remains broad and thick enough to cover the injury site and could definitely be used for larger ICA tear and combined with temporary packing. During harvest of longus capitis muscle graft, there are no critical neurovascular structure that are risk of injury. However, to prevent severe venous oozing from the petroclivar fissure, care should be taken not to cut the muscle too laterally. Although very rarely, anatomical variation with tortuosity or medialization of parapharyngeal ICA into a retropharyngeal position are possible. So, in that cases, you have to take care. Studying preoperative imaging carefully and using Doppler ultrasonography to localize the ICA intraoperatively can prevent vascular injury in the rare situation like this. Formation of secondary pseudoaneurysm is a common complication following injury to the ICA as high as about 40 to 50%. Now, relevant anatomy. The nasopharynx lies behind the posterior nares and extends from the spinotrostium superiorly at the level of floor of the spinosinus to the horizontal plane of the soft palate inferiorly. It is limited laterally by the Eustachian tube opening and fossa of Rosenmuller. The soft tissue of the posterior aspect of the nasopharynx having superficial to deep three layers. The nasopharyngeal mucosa, the pharyngovaginal fascia and nasopharyngeal muscles. The soft tissue of the nasopharynx cover the clival part of the occipital bone, the craniovertebral junction and the anterior ring of the atlas vertebra. The nasopharyngeal muscle are arranged in two layers. A superficial layer formed by the longus capitis muscle which originates at the anterior tubercle of transverse process of the C3 to C6 vertebrae and inserting at the superior clival line of the occipital bone, and a deep layer formed by the rectus capitis anterior muscle and originate at the C1 and inserting at the lower clival line of the occipital bone, and this is the rectus capitis anterior muscle which is originating from the atlas vertebra and inserting at the lower clival line at the level of foramen magnum. The longus capitis muscle is the preferred tissue for the nasopharyngeal muscle patch due to superficial localization, easily accessibility and broad and thick structure and size about 2 cm length, 1.5 cm width and 1 cm thickness. In order to harvest the longus capitis muscle, you have to make inferiorly based U-shaped flap by the monopolar cautery and underlying longus capitis muscle can be harvested, and depending on the size of required muscle patch the graft can be harvested from the longus capitis muscle anywhere between the superior clival line up to the superior aspect of the anterior arch of the atlas vertebrae and lateral extension will be limited only by ostia of the eustachian tube. And following harvest of the graft, muscle flap can be repositioned, and this muscle incision is not required any closure, and exposed tissue can be covered with the fibrin glue or gel foam after hemostasis is achieved.